So thanks a million for having me. And what I wanted to talk about was, I suppose, the research that I do in UCC. And a lot of that research is in relation to the relationship between mental health, addiction, and other outcomes such as homelessness, and what we know from research and why we should be designing that to service design and delivery. So I know Carol and Sean are going to speak in a few minutes as well, and I think that there's a nice kind of link between everything that we're saying. So I suppose the area that I research is psychological trauma, and not everybody who has a mental health issue and not everybody who's in addiction has experienced psychological trauma, but a lot of people have, and it's something that we're becoming better able to talk about. I think this isn't new. People who have experienced adversity in their lives know that they've experienced that. Sometimes when people would access services, there would be a lot, particularly addiction services, there would be a lot of focus on the addiction and maybe not enough focus on the reason why somebody had to use drugs and alcohol at a level that was causing them a lot of problems. So I suppose that the important thing about psychological trauma is that it is a unique individual experience. So, you know, myself and Sean Foy, for example, could be walking down the road and we could witness something really terrible happening. And one of us might be able to put our head on the bed that night and go to sleep, and one of us might not. Because we're very different individuals. Every human being is different and unique and has a different ability to manage experiences. So sometimes you hear people saying, oh, well, you know, I had a tough time when I was growing up and I didn't end up in addiction services, or I didn't end up involved in crime. You know, so that when somebody says that, you know, it's great for them that they were able to manage their experiences and that they had protective factors that pull them through, but not everybody is the same. And there are some people who have experiences and their ability to manage that is not as strong as others for lots of different reasons. And we have to stop, you know, comparing people to each other and accept that each human being is different and individual and unique. So what do I mean by traumas then? So we have small traumas and big traumas. So the big traumas are the things that we all imagine in our head. And then there's small little traumas that can go on for a long time. We all experience stress in our lives, and hopefully that's a tolerable level of stress. It's impossible to avoid stress. When you're a child, experiencing tolerable stress can be good for you because it can help you develop problem solving skills and decision making. So, you know, small little things that are little stressors are sometimes good for learning and growth. But where you come into trouble then is if you experience toxic stress. So that's where you just have too much stress all of the time and there's no opportunity to repair from that. If that happens, then a process called allostatic load can happen. So that's where our body really just reaches a point where it just says, you know, enough is enough. I can't cope with any more stress. And we can become physically sick. You know, lots of different illnesses can be caused by stress. We can become very mentally unwell. And sometimes part of being mentally unwell is using drugs and alcohol to be able to help us cope. So traumas then can happen, you know, it can be a single incident trauma, and that's probably the most common trauma, where it's an unexpected and overwhelming event like an accident or witnessing something bad. Complex trauma then is interpersonal and enduring traumas. These are often the things that happen in the context of relationships that ought to be helpful and caregiving. So things like domestic violence, which is very much in the focus now because the last year seems to have brought it up to the surface in terms of, you know, the amount of it that goes on. Developmental trauma then is particularly, I suppose, trauma in children, because when you're born, your little brain and your little body is still developing, and it's developing up until about the age of between 23 and 25 years of age. So being exposed to a lot of stress during your childhood and adolescence can make you a little bit more vulnerable sometimes to mental health issues. The good news with that is, I suppose, when I started studying psychology, we were always told that, you know, if somebody had experienced too much trauma at a very young age, that it might have a lifelong impact on somebody. Whereas we know now that the brain is plastic, So that means your brain is always constantly growing and changing. So if, like for me, I'm 45, so I'm middle-aged. So I'm supposed to be doing things like learning a new language or learning how to play the guitar so that I'm using parts of my brain I don't normally use, and that will help slow down dementia. So the good thing I think that has changed for me as a psychologist is the fact that when I started studying psychology, there was much more a kind of sense of helplessness really around people who'd experienced very, very high levels of trauma in childhood, whereas now we know that growth and recovery is possible for everybody. Intergenerational trauma, then, that's the impact of living with trauma survivors. So living with a parent who's had a really difficult time, and sometimes if you're a parent who's had a really difficult time, you can be anxious, and then you can become an anxious parent. And you can try really hard not to be anxious, but sometimes your anxiety comes out without people, you think you're doing okay. I give an example. Sometimes I get anxiety. Anxiety is okay. Sometimes it's good to have a little bit of anxiety because it keeps you on your toes. It's when it becomes a problem, you have to look at it. A couple of years ago, I was worried about something. And I was going, when I get anxious, I check windows and doors, and it's ritual checking, constantly checking. And I was going around all evening checking the windows and doors and trying not to let my family see that I was checking the windows and doors because I didn't want to make them anxious as well. So I was kind of secretly checking windows and doors. And then the dog needed to go out, and the husband was letting the dog out. The dog wouldn't go out, and he was shaking, and he's a big, scary dog, and it was unusual. And I said, oh my God, what happened to the dog? What's wrong with the dog? And he said, sure, you've given the dog anxiety. Because everybody in the house knows you're going around checking the windows and the doors. And the dog is terrified now. He doesn't know what's going on. And I thought nobody knew that I was going around checking the windows and doors. So sometimes if we're carrying a little worry or a little story that's impacting us, it's making us anxious, that sometimes it does impact on other people around us. And I suppose once you become aware of that, and you say, look, and you don't give yourself a hard time over it, and just say, look, sometimes I get these worries, and what I'm going to do is I'm going to take myself off to talk to somebody and help me manage those so that I don't have as much of an impact on people around me. Historical trauma, then we've lots of that in Ireland in relation to industrial schools and residential schools. And I suppose the fallout from that all of the time, we're still dealing with fallout from historical trauma in Ireland. And we could go back a really long way. And then the experience of immigrants, refugees, marginalized groups, and ethnic minorities. So to take, for example, our own ethnic minority group, the traveling community, only 3% of the traveling community live beyond the age of 65. That's an absolutely frightening statistic. So if I was a member of the traveling community, I'd only have about 20 years left in my life expectancy. And that's shocking to me. It's also shocking to me that if I was a member of the traveling community, that I'd be 6 or 7 times more likely to die by suicide than members of the settled population. We have to do more in terms of the way that we've excluded members of the traveling community. Irish people have a terrible graph for Native Americans because of the helping hand that they gave to us during the famine. And what's really interesting is if you look at, last year, Irish people raised €1 million and sent it to America, to Native Americans to help them with their COVID fund, because 1/3 of Native Americans did not have access to running water when the pandemic hit. 1/3 of the traveling community don't have access to running water either. You have the same issues in Indigenous groups all over the world. At the Aborigine community, the Maori community, the Native American community, and the traveling community, you have high levels of unemployment, school leaving, addiction, mental health issues. So if we're going to reach our love out to Indigenous communities around the world, we need to really take a step back and look at how we're treating our Indigenous community in Ireland. So what kind of traumas do I think about? So things like, this is not an exclusive list. It's there are lots of experiences that people have that can have an impact on them mentally. So things like bullying, poverty. People are often blamed for being in poverty when poverty is something that's linked to social policy. Poverty is one of the biggest predictors of mental health issues and physical health issues. Homelessness is a massive contributor of mental health issues. And we have 3,000 children in Ireland who are experiencing homelessness. The research in relation to mental health of children in homelessness has long been established. Peer rejection and having no friends, experiences of racism, death, multiple and traumatic loss. And if you think about the traveling community, there's an example, and very high levels of suicide clusters within the community, which is a profound impact on the adults and the children left behind to experience so much death in such a short space of time. Exposure to community violence. So that might be people who've come here from other countries who have fled war-torn regions, or it might be people who are living here who are living in areas where there are high levels of disadvantage, which has caused people to behave in ways that are difficult. Food scarcity, the experience of the care system, being excluded from education. I know it says poor academic performance up there, but I'm not talking about kids who didn't engage in school. I'm talking about schools that weren't able to hold on to children. And there's a very big difference there. Every child has their own unique gifts and talents, but our education system is very academically inclined. So there are lots of kids who struggle in school, and we don't have a system that holds them, and then they leave, and then we blame them for leaving. And then living in an unsafe environment. So that's things like abuse and neglect and other issues that can happen in your household. So what happens when you're very stressed is that your thinking brain is underactivated, your emotion regulation center is underactivated, and the fear center is overactivated. So what does that all mean, and why should we care? So here's your brain. So back here you have your fear response systems. This is your fight or flight. In the middle, you have your limbic system. So this is the bit that perceives and reacts to threat. So when Sharon Lambert's driving down the road and another car pulls out in front of me, this part of my brain notices that there's danger, and it tells my instinctive responses to kick in. And it says, right, you need to start something out or you're going to be killed in a second. So you slam on the brakes. Now, in order for that to work really well, what your brain does is it stops running non-essential services, because there's no need for non-essential services in an emergency. So one of the things that's non-essential in an emergency is actually analyzing. So if I'm driving down the road and a car pulls out in front of me and I stop to analyze it, oh, if I'm traveling at this speed and the light is in this direction, I'm already dead. So my brain is designed to keep me alive. I'm a basic mammal, survival of the species stuff. So what it does is it withdraws blood from my prefrontal cortex, which is my thinking brain, and it activates my fight or flight response system, and I slam on the brakes. So if you think about it, in a scenario like that, I know for me and for most people, you curse after you've slammed on the brakes, not before, because you slam on the brakes and then the blood comes back to your prefrontal cortex and you're allowed to think again. And you say, holy cow. That's not what I actually say in real life, but you say, holy something. And you realize that the danger is over. Now, that's fantastic when you're in a dangerous situation. Unfortunately, for some people have experienced so much stress and are so stressed all the time that their brain doesn't really understand. It's just kind of overwhelmed with the amount of stress that's going on. So it says, Sharon is in danger all of the time. So even when you're in places where there's no danger, your brain thinks you're in danger and it activates your fight or flight response system. So what does that mean if we work in services? Sometimes people arrive in and they seem really angry, but they're not angry. They're actually frightened. And their brain is doing exactly what it should be doing. It's activating the fight or flight response system because the person is stressed and frightened. So our job is to understand that, to take a deep breath, take a step back and say, what can I do to support this person? It is no good excluding people from services. The people who need our services are the most challenging, and they are the most excluded, but they need us more. So we have to be able to understand the impact of trauma on behavior. Another thing that's really important is that the prefrontal cortex isn't fully formed until somewhere between the age of 23 and 25. Why does that matter? Because a lot of our services at age 18, you transition from childhood services into adult services, even though the brain isn't a fully adult brain. Young people who were 18 years of age need a lot more support than somebody who's 30 years of age. So if you're transitioning somebody from a young person service into an adult service, you need to walk along with them for another little while. If you work in an adult service and you have young people under the age of 23, you can't apply the same rules to them. You have to cut them some slack. I did not wake up on my 18th birthday and start planning my pension fund. That does not happen. When you were 18, that's adulthood has been decided by some kind of legislation, but it doesn't match up to what happens in reality. One of the other things that's really important to know from research is that the best work that you do, particularly with young people, is in the context of the family. We are all part of a system. So I'm part of the system, I'm part of the family system. When there's 4 of us in our house. When there's something wrong with one of us, there's something wrong with all of us, no matter how hard we try not to let it impact on each other. That's a reality. So if you are an adult who's experiencing difficulty, the children need to be looked after. If you have a child who's experiencing difficulties, you need to support the adults as well. Because it's the whole system that needs help, not just individuals within it. So why do young people use drugs? Lots of young people use drugs recreationally. As a psychologist, I'm not interested in recreational use. But when young people use too much drugs and it's causing them a lot of trouble and they're getting into a lot of hassle, I can tell you something, they're not having great crack. And if they're getting themselves into an awful lot of trouble, we need to understand what is the motivation for taking drugs. So one of the things that young people tell us when they're overusing drugs to a point that it's become very harmful is that it stops them from feeling. You just don't feel anything at all. And we have to listen to that. If somebody's trying to numb out their feelings, we have to listen to what's going on there and what kind of feelings are they finding very difficult to manage. Focusing too much just on the substances does not give you the full story. I'm not going to talk too much about this because Carol and Sean are going to talk about what happens when you have mental health and addiction at the same time. For me, addiction is a mental health issue in lots and lots of cases. In a lot of the research that I've done, here's an example where we looked at adults in a residential addiction treatment service. And what we found was that a very large number of people had experienced traumas. Not everybody, but a large number of people had experienced a lot of traumas in their childhood. And what we found was that the more adversities that they'd had during their childhood, the higher the reports of mental health issues, suicidal ideation, higher levels of imprisonment. And this is an important one for me in terms of service delivery, more treatment attempts. So people who'd experienced the most adversity needed to attempt treatment more times. So if somebody goes to addiction treatment and they drop out halfway through, or they have a relapse, people can get very disappointed and they can see it as a failure. If you're trauma aware, you don't see it as a failure. You see that that person gave it a really good shot. Something has not worked out so well. So what we need to do is reflect on that and see what we could do differently. But we have to recognize that some people will not get it first time, second time, or third time. Some people might need to try 7 or 8 times before it works for them. And that is shown in the research, in particular with people who've experienced high levels of trauma. If we want people who've experienced high level of trauma to have a really good opportunity at recovery, we have to think about the research and what it's telling us, and we have to apply that to how we deliver our services. So just to give you an example of trauma within homelessness settings, you'll see here in yellow, this is some adults from the Cork Simon community here in Cork, and their experiences of childhood trauma during their childhoods. And in homelessness, many people experiencing homelessness also experience traumas, physical violence and sexual violence. So they have not only have had childhood traumas, they also have adult traumas down, compounding that. But if you look here, you can see in yellow that people experiencing homelessness in Cork City, in the main, had walked a very different path than the people in the green, which is the general population. So when I think about people who are experiencing homelessness in Cork and the people that I've met and some of the stories that they've told me about their experiences, and then I see them lying on the street after using heroin, I don't think badly of them. I think that they're incredibly resilient and incredibly brave, because but for the fact that they're using drugs and alcohol, they might not be able to manage their emotional distress. And when you talk to them, many of them would tell you that without drugs and alcohol, that they would probably die by suicide because they just cannot cope with their mental distress. Unfortunately, because they use drugs and alcohol, they find it very difficult to access mental health services. And Carol and Sean will talk more about that. I've already spoken about the traveling community and about making our services work better for the traveling community. In order for people to be well, to have good self-esteem, and to have good strength, you need to have your very basic needs met: food, shelter, and water, and safety. And last week, the Ombudsman for Children issued a report in relation to traveller accommodation in Cork, and in relation to the appalling conditions that children were living in, despite the fact that Cork City Council returns its traveller accommodation budget unspent every year. So children, where there's money available to look after their accommodation needs, that money was being unspent, and children were living in very difficult situations, which has a huge impact on their, sorry, my postman is waving in the window at me, which is a huge impact on their mental well-being, their physical mental well-being. And you can imagine, if you're living in a situation like that and you arrive into school in the morning, are you ready for learning? Are you ready for learning when you're arriving in, so stressed out? So what can we do about that? The time for talking is over. We have significant research from Ireland and abroad about the relationship between trauma, mental health, addiction, and homelessness. So now we need to start getting it into policy and practice. By having trauma-informed organizations, not just mental health, not just addiction, all organizations that have to deal with human beings, starting from very young, primary schools, secondary schools. The longer you keep children in education, the better their outcomes. And catching people upstream, so trauma-informed creches, trauma-informed schools. Then when people reach adulthood, trauma-informed social protection, trauma-informed housing agencies. So having safety, like physical and emotional safety, trust, providing consistency and clarity, maximize choice and control. So having things like harm reduction. If you're offering an abstinence-based program, there are lots of people that can participate in that. But there are some people who can't, and we have to be able to meet the needs of everybody. We might need to work a harm reduction program with somebody for a number of years before they can even consider abstinence. That's not a failure. That's just understanding that every individual is different, and what you can achieve and what somebody else can achieve is different. And we have to stop being judgmental about that. Having good collaboration between child and family and all agencies, prioritizing skill building. A lot of signs in buildings are all about what you can't do and what you shouldn't do, instead of thinking about what you can do. And having cultural and gender competence. So this is to give you an example of, in order to feel safe, people need to feel seen and heard. So these are some quotes from a study that was done by one of my doctoral students, Donald Moynihan, who's now graduated and gone off into the world. And he looked at young men who presented to A&E with very serious self-harm and who left without being seen. So this is some of the reasons why they leave without being looked after. I know they're busy and things, but it would only take 2 minutes to come over. And even if it was every 5 minutes and say, oh, somebody else came in that's in a worse condition than you, and we have to deal with them. And then Owen says, you're having a conversation with yourself and the psychiatrist, even though the psychiatrist isn't even there, thinking if he'll believe me. Does he know how bad I really am? What if the doctor had my head for a couple of seconds? Imagine if I could take that out and hand it to the doctor and say, now, doctor, take a listen to that. And he's pointing to his head. Some of them, I really did not want to answer them, but others were talking to me directly and trying to understand me, but others were asking me really generic questions that I just didn't want to answer. The guy I was telling you about was just sitting there talking to me as if I was a friend of his, and wasn't just giving me generic questions, just talking to me like a human being. I recognise now that a lot of services have to produce outputs and KPIs and have become very heavy in paperwork. You do not form a good relationship with somebody if you sit down with a pen and a paper and start ticking boxes because some funder somewhere has decided that you have to fill out this form in the first session. That's not appropriate. Yes, there's information that needs to be collected, but that should be done over a period of time. And people are not, you know, lab rats where you sit there and you ask a load of impersonal questions and tick boxes. Now, a lot of the work that I do can seem a bit dark and a bit bleak, but I have got lots of reason for hope. I see lots of grassroots changes. I see lots of people joining up the dots. So for example, for me as a psychologist, I understand that it's not good enough to just talk about, for example, if I take children in homelessness, it's not good enough to talk about challenging behaviour in children in homelessness without acknowledging the fact that they're in homelessness. So lots of people are beginning to realise that for people to be physically well and mentally well, that we have to talk to each other. We have to influence policy and practice and change. And I see huge change, you know, not only within organizations, but also within the general public. So even in the last couple of weeks to see, you know, the public getting really annoyed about housing policy in Ireland, and people who have their own houses and have their mortgages and they're all set up, being really annoyed about it too, because people are starting to understand that for us individuals to do well within society, we need everybody else around us to have the same opportunities. And I definitely see a lot of that happening, and I have great hope, and I've particularly great hope in relation to young people. Young people are amazing, and they've really shown us that in the last year. So that was a very quick overview of the kind of things that I deal with that normally takes about 3 hours for me to talk about, but I've done it there in about 20 minutes. So thanks a million for listening.
Thank you so much for that, Sharon. As always, a really, really insightful presentation. I think it is so important to hear the voices of service users, and it's great to see that they're in concrete research, because then you can work off of that. And I think the Cork-Simon study there, just really, that visual really stood out to me. The difference between that particular cohort and the general population it's scary. I suppose to be seen and to be heard and have connection is the most basic need from everyone, and I can just hear that from what you told us there. And drugs, it's not just a coping mechanism, it's also a survival mechanism for many, many people. And what really stood out to me as well is, especially from the family support perspective in the drug and alcohol, is when something's wrong with one of us, something's wrong with all of us. And that is so true. If someone has an addiction or a mental health issue, the whole family is on the ground with it. So thank you so much for that. Next up, we have Carol Moore. Carol is someone who has really worked to get these voices and the needs of service users and families heard. And she's vast experience of leading positive change with many organisations. She's the co-founder of Dual Diagnosis Ireland, which works towards making the right services available at the first point of asking to both people with mental health and addiction issues. Accessing the right service at the right time has been a huge issue for many families that I come across over the years. Sometimes that even leads to exclusion from services. So it's a really, really important issue. So I'm really interested to hear from you, Carol, and a very big welcome and thank you for joining us.
Great, thanks very much, Mark. So hopefully people can see a screen now with a picture of a chap cut in half. We'll just put that on slideshow. So basically, I'm not a healthcare professional and I'm not an academic. How I came into this area was family experience. And I've been in the healthcare, I am in the healthcare system myself for quite a long time. So when this person got ill, a family member, I was enlisted to help out. That's when it really became clear what a huge problem this is. So when that person died, we set up Dual Diagnosis Ireland, and we're coming at this from very much a lived experience perspective. We can be a bit provocative. What I've tried to do in the presentation is include links so people can actually look up what I'm saying. So this is not an academic or a healthcare professional. This is Dual Diagnosis saying we think this is an artificial problem caused by the way we design systems. And Sharon has really indicated one huge problem, that we don't design systems to be trauma informed. And then in the case of addiction, made a lot worse by stigma. So let's see if the slides are working. And my screen has frozen now. So, and this was working earlier in practice, but not working now. So I'll escape out of it. The screen just seems to have frozen altogether. Now we will be circulating the slides, so I can't get them to work. You'll certainly have them, and I can certainly talk to them. I'll stop share and see if it works, and then try it again. Okay, it's working when I stop share, so we'll go back in and see, can we get it to work this time? Right, so I've done the introduction. So what I'll do, and hopefully if the slides continue to proceed, we'll go into the just an overview of the systems that are there at the moment, a very brief overview, whistle top. In 20 minutes, there's only so much you can achieve. And then looking at the impact of stigma in terms of how it influences people and the systems. And then just a quick few tips on how to actually work the system to get the right help. So in looking at it, which kills most people? And it's interesting because in cervical cancer, which has its own screening system, and we screen for cervical cancer, 6 to 7 people die every month. We have an agency, a dedicated agency, which looks at road safety and has had great progress in actually reducing the number of people killed by road accidents. But then when we look at illegal drugs and alcohol, despite the World Health Organization recommending screening of every patient in the healthcare system annually, we don't do any screening for alcohol, very, very limited. We've no agency that looks at alcohol, a statutory agency, or that looks at illegal drugs, even though these two areas kill far more people than cervical cancer and road accidents. So it shows you the level of priority. And there's a huge gap in treatments. The Health Research Board states that about 1.5 million people abuse alcohol. So that ranges from just drinking harmfully to the higher end of physical addiction. So the recorded treatments, now this is what we capture officially, it's anything between 8 to 10,000 in alcohol. So, you know, all this we're just not addressing. And then in mental health, a little bit better, but again, still a huge gap in the recorded treatments. So you can see not a lot of priority assigned to it. And there's a lot of governance issues. I've just pulled out a couple of examples. Roscommon Mental Health Services failed to report the risk of inappropriate sexual behaviour. So patients were experiencing yet more trauma in the services. And then on the drug task force side, we've actually had a drug task chairman actually jailed because of governance issues. And in general, and this is not me saying this, this is actually a report, and you can see the link there, treatments aren't based on evidence. They're not based on the evidence that you've just heard about from Sharon. There's no scientific research and program evaluation. And it's not just an Irish issue, it is an international issue. And in some residential services, daily mass is mandatory. Now, there may be benefits to daily mass, but in terms of clinical benefits or therapeutic benefits, there's no evidence for it. But yet in some state-funded services, there's still an insistence that you have to get daily mass, otherwise you are not allowed to stay in the service. And we see huge failure rates. Now, we know addiction can be a recurring relapsing disease, but when 75% of the cases coming through have previously been treated, you know, and we're not actively working with a huge focus on reducing that, no other area of healthcare would accept these failure rates. We're also seeing a lot of dissatisfaction in mental health services as well when you do get out to them, like a massive 41.6% of people believe mental health services are poor. So we have a lot of deficient services where we're not measuring success rates in terms of user experiences. A lot of them are purely abstinence-based. They don't look at harm reduction. A lot of services are not regulated properly. And despite the fact there's a 6 billion economic cost, even forgetting about the human cost, really, there's, you know, lack of priority really assigned. And we plan services to treat conditions. So if you have a range of different conditions, you've got to go into, you know, all these different services, and you've got to navigate your way through these services, each of which have their own referral criteria, their own model of knowledge, how they work. And it really is very difficult for people to navigate their way around services. And, you know, there's a huge burden of care for people. And dual diagnosis isn't, and Sean is going to go into more detail on that, but it's not just about mental health and addiction. Dual diagnosis also occurs when you have a physical health issue, which brings mental health problems with it, but yet we don't design services to help people with that. And a lot of our addiction services, they tend to be very intense and confrontational. They're designed to break down denial and resistance to his or her addictive disorders. And we expect clients to have some awareness of the problems. So a lot of services won't accept clients if they're actually actively using drugs. They say you have to be clean, which again is problematical language. And it's only now that the newer treatments that are coming in are more supportive, benign and non-threatening. But we still, from the research, know there are services which are actively screaming and shouting at clients, which is totally unhelpful, as we know from the trauma presentation that Sharon made. So the other big issue is we keep telling people if they're in trouble to go to emergency departments. But we do know from various different reports that when people present in emergency departments, and we saw that in Sharon's presentation, a lot of the time they're discharged because staff aren't actually trained to deal with them. And personally, I know of quite a few cases where people actually died after being discharged. So that's a real problem as well, that there is this lack of training for staff in the emergency departments. And then if we get into stigma, stigma is a mark of disgrace associated with a particular circumstance, quality, or person. And this really has an impact on people, because when we internalize stigma, and we see this with the travelers, so few of them actually live beyond 65, it's because they're seen as being bad people. And the trouble is, because of that stigma, the models of care we adopt through addiction are wrong. You know, they don't work. And what we need to do, as Sharon has explained this, we need to understand what relief is the person with the addiction getting. What do they hope to find in the drug or the addictive behavior? And again, if you're not familiar with Dr. Gabao Mate's work, I'd recommend. He's on YouTube and he's written a few books looking at that. One example of stigma, this is a notice in a GP centre that's dispensing methadone. And on the wall it says, all urine samples must be provided within 5 minutes of request. And if you don't do it within 5 minutes, it will lead to them not giving you your methadone or decreasing your methadone dose. And if more than one refusal may result in detox from the program. Now, when I'm in hospital and somebody asks me to give a urine sample, I can't do it within 5 minutes. And that's where, you know, I'm in hospital for a physical treatment. So how does that relate to the HSE values of care, compassion, trust, and learning? So somebody, you know, going in for a methadone, trying to get better, you know, obviously if they're on methadone, and yet they have to provide this urine sample within 5 minutes or they'll be kicked out. You know, it's no wonder in one sense that people with addictions become so challenging and difficult to deal with, because they're getting all these messages that they're worthless. And if we look at AA, and I'm a great believer in peer support, and I think it's essential, and there are thousands of people alive because of AA. But we do know from the research that the success rate is quite low. That would be okay if it was helping those people. But the other problem is in AA, it's all about abstinence. And if you don't drink, or if you have a drink, you failed. It's not that, well, I stayed off the drink for 100 days and now I'm back to, you know, I've done well. It's, no, you failed. And the other message that AA gives, that everyone believes AA is the right treatment. And AA is never wrong according to AA. So if you fail in AA, it's you that's failed. And medication is frowned on. I know of many people who are told, come off your medication when you join AA, or you're going to an AA-based treatment. So it's a real problem. And even, you know, GPs referring to AA, and they're not even aware of the governance issues that related to AA. And in America, they have what they call the 13th step. There's a lot of research which showed that the 13th step is when a trusted advisor in AA, a mentor, then makes a move on more vulnerable people. And there's quite a lot of that. And we've heard of some cases here in Ireland as well. So that is a real problem there, even though the peer support of it obviously keeps people alive. But so many treatment models are based on AA that there's no option for people to look at the harm reduction that Sharon mentioned. And this stigma is everywhere. After the death of yet another person who was homeless, the head of the Dublin Homeless Executive said, let's be under no illusion here. When somebody becomes homeless, it doesn't happen overnight. It takes years of bad behavior, probably, or behavior that isn't the behavior of you and me. So we've heard from Sharon that trauma is very present in people with severe addictions. You know, 90+% of people have it. And then they go and they try and get help. And then that help isn't tailored to their needs. So then they feel like a failure. So of course there's going to be bad behavior. Of course they're not going to behave the way you and me, but blaming them for it, you know, and particularly when people are dying, to me, it just shows a level of stigma and the lack of understanding of our services in terms of helping people. So we need to think about how we talk about addiction. We need to stop using terms like junkies, druggie. You know, we need to talk about putting the people first, people with addiction, people who are fighting addiction. And even the term clean and dirty. I really hate that term, because if you're saying you're clean, well, that applies when you were using drugs, you were dirty. So that's not helpful, because we internalize those messages and we believe we're nothing and we're, you know, filled with shame and guilt. And how can we actually recover if those feelings are so strong? And as Tanya Barnett, who's a leading clinical psychologist in England, says, you know, why bother to try when you're told that you are a failure? Why bother to strive when your existence is seen as a nuisance? So every time somebody realizes they have a problem and they attempt to get help, you know, they're turned away, whether it's the emergency department, whether it's, no, you have to be clean before you come to this service. So the messages we're sending people create this self-fulfilling prophecy that once you're an addict, always an addict. So it's time not just for a change of service, it's time for a paradigm shift, because the current paradigms, and the paradigm is where there's a model of knowledge which dictates how services are provided or dictates how healthcare professionals are trained. And in order to be a healthcare professional, you have to accept that model. We really have to change how we're looking at addiction and mental health. And currently, we're all about the medical reductionist paradigm. In the clinical program that I was involved in a few years ago, was about creating a specialist dual diagnosis service. But the more and more specialist services we create, the more difficult it is for people to access services. And particularly in addiction, you have to get people, when people want help, you have to get them the right type of help at the right time. So, you know, we don't need more specialist services. What we need to do is dig deeper. We need to move beyond the medical model. And as Sharon has explained, we need to look at poverty, inequality, oppression. You know, we've heard about how homeless children are much more likely to suffer. And yet, as Sharon says, we have 3,000 homeless children. Injustice, trauma. You know, we have a legacy here in Ireland from the baby and children homes. We now have people in addiction services who are being abused. So we can't tackle this problem on an individual level, you know, where we see the individual as a problem. Yes, they have a responsibility to look after themselves, but we need to create the support structures and a society that actually supports people. And we're seeing now with the pandemic that more and more people are having mental health issues, more and more people are drinking more. So that shows you the impact of our society and our structures on the individual. So we've really got to develop systems which are grounded in social justice and grounded in intersectionality, looking after all the issues, not just blaming the individual. And there is some changes. some hope, as Sharon would say. Very interestingly, the HSE clinical model of care for psychosis, early intervention in psychosis, which came out in June 2009. And what that actually said, to exclude this group, i.e. people who had drug-induced psychosis, or who up to now would have been excluded from mental health services, would be akin to excluding cigarette smokers with heart attacks from coronary care units. So this is a really, really significant change. And it's interesting because not a whole lot of people know about it. So if you have a client or a family member who has psychosis, then you can actually be treated by specialist mental health services. You can actually access a hospital bed if that's what is needed. Right, so this is really, really positive, and the more people that know about it, the better. So I have the link there. And I think it's really good to see that statement, akin to including cigarette smokers with heart attacks from coronary care units. You know, and that's what we're doing at the moment with people with addictions. We're excluding them from mental health services. So it's just terrific. That's a really positive change that we're very happy to see. And then the other thing that's happening in society generally is this chap here is talking about dual diagnosis. He says trauma caused him to suffer anxiety and severe panic attacks from ages 28 to 32. I was just all over the place mentally, and he tried to mask his emotions. Again, very, very similar to what Sharon found in her survey. But fortunately for Prince Harry, he was, and he has said this in a TV program, he was able to access psychotherapy, good psychotherapy. So he was actually able to address these issues. And you'll never see the words dual diagnosis talked about Prince Harry, but that's essentially what it is. So in terms of working the system to get the right help, because it is an incredibly complex system, on our website, we produced an A to Z. Now, it does need to be updated, but for people who are unfamiliar with the system, it's a very down-to-earth user guide, which goes through all the different aspects of the system, from first-line services to free services to private services, and just gives you an example of each and what they do. And then it goes through the different types of treatment, the medical treatments, the types of medications, safety, hospitals, what your rights are in hospital, the different types of therapies, psychological treatments, lifestyle and alternative treatments, and then the value of it, getting a diagnosis. So we've drawn that from a wide range of sources, the Mental Health Commission, various addiction websites. So for somebody who's new into the system, if you've been around a while, you're probably familiar with it, but for somebody who's very new in, it's a useful kind of overview, and it can be downloaded as a PDF. Quality frameworks, really, really important. And there are actually quality frameworks. There's the quality framework in the specialist mental health services, generally where you have psychiatrists. And then there's the quads program in the better drug treatment services. So they really, there's differences between them. And the mental health framework is out for consultation at the moment. And I'd encourage everybody who's ever had an interaction with the mental health services to give some feedback on it. But basically what that does is it says you should have a care plan. So everybody going into a specialist mental health services, and there's something similar in the addiction services, they should have their diagnosis listed, what their medical problems are, review dates, questions about how the person feels about their mental health and their own care, setting goals, what are we trying to achieve, mental health needs, physical health needs, very detailed, as you can see, activities of daily living, skills of independent living, social skills, and even discharge plans. And what we found in the experience we've had with people is that a lot of the time it's ignored. And people, when we ask them, do they have a care plan? They say yes. And then it turns out to be a prescription. A prescription is not a care plan. And this is, under the quality framework, people are entitled to this and they should be consulted and they should sign these plans. And the Mental Health Commission reports on a regular basis when it does inspections of the centres as to how many patients in the system actually have care plans, and regularly it finds people don't have care plans. So if you're trying to advocate for a patient or a loved one, this is something to ask for and to read through. And then documentation. There are so many fine healthcare professionals working in the services, but we know there's not enough money spent on services, so they're overwhelmed. They're just under so much pressure. COVID. Now the cyber hacking, it's for many people, it's nearly an impossible job. So ringing is helpful, But if you really want help, you need to document, you need to put in your letters so that the letters are an audit trail of your attempts to get help. We find that generally works better than making phone calls. And we have sample templates on our website. So key letters asking, particularly when people are being bounced between services, asking who is overall clinical responsibility and CCing everybody that has ever had any involvement, from the social worker to the drug task force to the psychiatrist. We have samples of agreement to share information, because that's often a problem. We saw that in a recent tragic case where it may perhaps, if the family had been involved, deaths could have been averted. So there's a range of letters there to help people who may not be familiar with writing these type of letters, to give them a start, and they can be downloaded and edited. And then the other big development, and I'm not sure whether it's happened in Mayo yet, is really good work that in the specialist mental health services, they have what's called service user engagement forums. So they have peer support workers now, and working with the management teams, the peer support workers have a local forum where they meet, they share experiences. They should be happening every month. And it's basically to listen to the experiences people have. And obviously, the more people that are going there and raising this issue of dual diagnosis, the more likely we are to get change. So change is possible. You know, it is, particularly if you're a family that's gone through it and are going through it, and you've lost somebody, it's very, very difficult for people. But we are seeing signs of change, and even the psychosis program, you know, that is a major change, and we would hope that would start moving down throughout the system. But it does depend on service user feedback. So I'm getting the nod to finish up at this stage. So I'll say thank you, and obviously we'll take questions afterwards.
Thank you so much for that excellent information, Carol. The revolving door in treatment is such a big issue. Such a great insight there into why both mental health and addiction should be treated together, and the importance of meeting the person exactly where they're at and not where we think they should be. The service user is the expert of the situation, and their needs and their goals need to be at the heart of treatment. I call it a bubble when people have an addiction or mental health issue, that they themselves can find it hard to see the full picture of their own life. And I think it's so important then for us to be compassionate and accepting of their life experiences, so they will be able to accept where they're at themselves. So thank you for that. Just before I introduce Sean, I'm just going to show a really short video. So us as a development group, when we were planning this particular topic, we thought it would be lovely just to bring a small little bit of real life experience into it. It's just 3.5 minutes long. We can talk about the theory and the concepts here at this level, but we just wanted to bring a small little bit of real life experience into it. So just bear with me now, and I'm just going to share.
I'm someone's daughter. Eating disorders as a way to cope with addiction. I battled for years to try to get them to see the light of their ways. Now, I prioritize myself and my recovery. I have learned to detach from their drinking, and I now know that it does not define me. Yes, the daughter of an alcoholic is what I am, but it is not who I am.
I am someone's father. I didn't know how to communicate with my son, so we stopped talking at all, except when we fought over his drug use. I was constantly worried about where he was and for his physical and mental health. I got support and learned more about addiction and not to be afraid of talking about it. I started to understand my son more and seeing him in a new light. I learned almost a new language, and our relationship really started to improve.
I am someone's sister. I was constantly worried and anxious about her safety and by how much pain she was in, and I was constantly missing the person that I knew and loved. After so much relentless anxiety, I I finally accepted that I couldn't save her, that she didn't want me to. I cut communication down to focus more on my own life. Although it eased the daily dread, it still hurts when I meet her. I continue to hope she'll find her way back.
I am someone's son. I grew up in a home surrounded by drugs and mental health issues. I turned to drugs myself to cope with it all. It was all I knew. I found someone who believed in me, who accepted me as I was and saw my potential. I started to believe in myself, and I broke the cycle and turned my life around. I went back to education, got my own house, and got involved in things in my community.
I have been surrounded by addiction my whole life, from family members and friends to relationships, and eventually fallen into addiction myself. I never imagined a life that didn't revolve around addiction, trauma and pain. With the right help and support, today I am free. I live a peaceful life full of love, joy and opportunities. Today I give my daughter the best possible chance in life.
I am a mother of a beautiful child that struggles with mental health and addiction, a dual diagnosis that led me to a place of despair that impacted in my physical, mental and emotional state and led me into financial crisis and circumstances. Struggling, searching for support services that understood led me to feel deflated, exhausted, but finally someone understood and listened. This, in addition to self-care and stepping back, helped me in my recovery to cope, giving a sense of hope. I am now so grateful for that, and today my loved one seeks recovery. I am so thankful.
Thank you to those people for sharing those stories. They were voiced over as well, just so that you know that. I think it gives a really little bit of insight into the real issue. So 2 questions were asked. How were you impacted by alcohol and drugs in your family? And how did you cope? So I think there was a lot of interesting little bits there, just a small insight. Thank you for sharing them. So next up now, we're going to have Dr. Sharon Foy. Sharon is like our resident expert here in Mayo on all things addiction and mental health. Every time I work with Sharon, everyone always really enjoys his talks. So he's a clinical psychologist, currently lectures in the psychology program in GMIT, and he manages a Learning Curve Institute training and his own private practice. I'm not sure he sleeps, but he has lots of experience here to share with us today from his range across different community settings. So thank you for joining us, Sharon.
No bother. Thanks very much for inviting me. It's really good to be here, and especially with Sharon and Carol. Just thanks very much for inviting me. So what I'm going to do, I'll tell you what I'm going to do in just a few seconds, but just to introduce myself, my name is Sharon Foy. I'm a clinical psychologist now working in Mayo. But I had a really interesting life before all that. I used to be a bartender in New York, which is a whole other webinar that we just can't get into right now. But also, I worked with people who were experiencing homelessness in the UK for about 10 years, and then I worked in a drug service for about 11 when I moved back to North Mayo. And look, throughout my career, which is just coming up on 30 years now, you know, dual diagnosis has always been the thing, right? So it's always been the thing. So it's been a very interesting kind of journey for me as a professional, and just purely on the basis of like, what's going on? Like, just what's going on? Can we not do a little bit better? Can we not do a little bit better? So I'm just going to share some stuff with you. The other thing too is there's a huge Cork link with everything that's going on today. Obviously Sharon's in Cork, and I worked for a group called Housing First in Cork for about a year. I just finished last year, and it was one of the best jobs I ever had. And we worked with people who were experiencing homelessness, and also many had a dual diagnosis, and so it was a beautiful team to kind of work with. Not necessarily easy work or anything like that, but just from a clinical point of view, it was just amazing to work in a slightly different way. So I can talk about that later on if you like. So what I'm going to do with you in this little presentation is I'm just going to look at dual diagnosis, and we're going to look at what life might be like for someone that has a dual diagnosis. And I'm just very conscious there's a lot of people in the group, and so we probably have people who have lived experience. And just to kind of say that, just that we're going to try and look at what it might be like for somebody who has a dual diagnosis, but then actually accessing services, like just trying to get into a service. We're going to talk a bit about that. And then I have some recommendations at the end, which I like to put in. I don't know if anybody's ever going to ever implement them, but I like writing them anyway. I think if I say them enough, they might become real. So what exactly is dual diagnosis anyway? Well, it's this is some thoughts that I've kind of nicked from Carol. So thanks very much. But so dual diagnosis, to my mind, and I think to a lot of people, is an artificial problem created by a healthcare system design and made worse by stigma. That's certainly the way that I kind of look at it. And in my career, I've had some very interesting things where, I've been trying to get people in to services, into say maybe a mental health service. And my experience of it on the ground has been, look, the main issue is substance misuse, and you need to kind of knock that on the head. And if you stop taking your substances, then you can come in and we can kind of do a bit of work with you. But as Sharon said kind of earlier on, a lot of times the thing that kind of holds people together actually can be their drug use. And it would not be uncommon for people to say, look, if I didn't have heroin, I wouldn't be here. And so I think it's just important to kind of to highlight that. And again, as Sharon said earlier on, it's not that people are having the time of their life when they're involved in an addiction or anything like that. But all you're trying to do really is to get through the day and to medicate, to just try and survive this thing that you're experiencing that you call life. The idea is that we try and see the person and not the problem. And I think one of the problems with healthcare design is that we're really good at hiving off. You work with the mental health, you work with the addiction, and there's this kind of notion of specialisms that are out there. My first degree is in social work, and when social work first started, it was a generic profession. There was no specialisms. It was just a generic profession, and over time it became specialized. And there's a huge argument about how people may have been de-skilled by experiencing that. So if I was a social worker 40 years ago and I was working, I probably would have worked with everybody. But if I'm a social worker now, I probably have to specialize working in a particular area. So I think, as Carol was kind of saying, it's not about trying to reinvent the wheel here. I think if we have more compassion, understanding, I was going to say training, and obviously we need training for professionals, but you're talking about a cultural change. That's really what we're looking at here, to my mind. Just to, as they say in New York, to completely own what I'm saying to you. I think we're looking at a cultural change. That's what needs to kind of happen. Be aware of trauma. Sharon's been brilliant just explaining that this morning. But just be aware of trauma. It can be there, and oftentimes it is. And peer support can really help. And we're very lucky here in Mayo. We do have a very healthy group of peer support workers that are actively working with people. So I think this is great. And later on in this presentation, I'm going to talk to you a bit about the recovery model in mental health, because there's a lot of similarities between the recovery model in mental health and substance misuse. My thing has just gone there. I'm really sorry, my screen has gone completely blank.
We can still see some thoughts slide.
Yeah, we can see your slide, Sean. Take your time.
I'm glad I'm not the only one who had problems.
John's helping you out here, Carol, by making.
Oh, you're just trying to make me look good, yeah. Sean, are you?
Just in solidarity, Carol. Always. Just give me a sec here, guys.
Yeah.
No problem. Take your time. Actually, just while you're getting that up there, we will have Tracy delivering the support services list available in Mayo. Just, if anybody has been affected or wants to follow up in relation to a comprehensive list of all the services there in Mayo afterwards, I'd recommend, if you're from a different area, to check with your local drugs task force. There's many of them scattered around Ireland, or even your family resource centres. They're a great source of information as well. You know, if you need to link in with anyone in relation to anything that came up today. And at the end then we will also have Becky, who will do a small raffle for some books and a lovely little hamper just for the attendees here today.
Okay, so I'm really sorry about this. I just can't see anything in my screen, but I know that I have dual diagnosis and artificial problem created by healthcare design. So I know I have that up. I don't think I can kind of move on. I'm really sorry, but what I'll try and do is I'll see if I can move this here. Don't know. Yeah.
Would you like me to share your slides, Sean?
Well, I tell you, if you would, Mags, if that'd be all right, if you could share them, and then I'll just talk through them because I actually have a copy here, so it's no bother. Again, I'm really sorry for everybody, but just this is the nature of the way we live now, right? It's just the way it goes. So if you can share it, that'd be great.
Yeah.
We're just coming up for slide number 5.
Slide number 5, okay.
It's just the one with the elephant.
Now.
Can you all see that? Can you all see the elephant?
Yep. Yeah.
All right, cool. So look, healthcare professionals are taught to approach addiction and healthcare separately, and it results in this type of thing. So this is something that Carol has sent me as well. Thanks again. I'm just kind of crediting you, Carol, with this. I just think it's a fantastic thing because I think it just completely encapsulates what I experience when it comes to working in dual diagnosis. And really, the bottom line is it's an elephant. And sometimes it's the elephant in the room that nobody really wants to kind of talk about. And I think in some ways, dual diagnosis is a bit like that. It's a bit like that. Mags, if you could go to the next slide, please. It should just say dual diagnosis, and there should be a little bit of a metric there. Is that up?
Yeah.
Yeah, we can see it.
Okay. So what I just draw your attention to is when I work with people who experience the dual diagnosis, I often draw this out. So you see there that there's one line and it just says the severity of mental health problems, low and high, and then the severity of substance misuse, low and high. And what I often do with people is I try and just draw it out with somebody. And you can see if somebody had a serious mental health issue and also a serious dependency. The example that's given is that they may kind of use, if they had a diagnosis of schizophrenia, and obviously there's a huge debate about the diagnosis of schizophrenia in and of itself, and there's no blood test for schizophrenia, just to say that to you. But in a situation like that, somebody might actually be kind of smoking cannabis in order to deal with kind of social isolation. And then the lower end, which is the bottom left-hand quadrant, is essentially somebody who might just kind of might have mood fluctuations based on kind of using substances like dance stuff, you know. So the next slide is implications of dual diagnosis. If you can put that up there, Mags, and just let me know that you've done it, and we'll kind of sort it out.
Yep, up there now, Sean.
Great stuff. So what we have, some of the implications we have for dual diagnosis, and obviously if you have a loved one who's been affected by a dual diagnosis, or indeed if you have a lived experience of it, you'll know all this. An exacerbation of the problems, or the symptoms rather, non-compliance with meds or treatment, sometimes, not always, increased relapse rates and severity, and again, totally understood because a lot of times people don't know where they need to go. The cost and use of service, it's as Carol said earlier on, it's so expensive the way that we do it. It just doesn't make any sense at all. Increased risk of violence and offending, increased risk of suicide, and higher incidence of homelessness. All stuff that is nothing new, I would imagine, to any of you. But at the same time, just interesting to kind of cover it. If we just go to the next slide, Max, thanks. Is that up there?
Yep, gone through, Sean.
Great stuff. Thanks very much. So, yeah, just increased risk of bloodborne virus infections, more complex intervention strategies. You could argue that maybe this is what's going on. Maybe the reason that we haven't got a service that I think is kind of fit for purpose in relation to dual diagnosis is because we don't have these complex intervention strategies. They're going to take a bit of time. We need people who are skilled in it, and we need to kind of do it. So I just wonder if that's maybe one of the stumbling blocks to achieving it. Increased burden of family and carers, and a rejection by psychiatric services. Certainly that's been my experience on the ground working. I've often sat in A&E for 10 hours with a client to be discharged, and not necessarily with any meaningful follow-up, you know. Now, I think things are changing. But I think it can be patchy, and it kind of depends on where you live. There is greater complexity in diagnosis and assessment. There's no getting away from that. And that's where the skill comes in. So we need to allow for that. And better pre-morbid function. People were doing better before they become unwell, obviously. Just the next slide, Max, thanks.
Okay.
So up in front of you there, you'll see 3 models. It's very interesting doing this presentation because I'm literally looking at a blank screen. So it's quite interesting for me. So there's 3 models that are there for you to think about. And what I would ask you to think about is, which one do you reckon is the one that is in your area? So the first one is a serial model. So this deals with either the substance misuse or the mental health problem individually, depending on which service the individual presents to first. Sometimes a serial model can be referred to as the sequential model on the ground. So basically, you need to sort out your addiction first of all, and then you come into mental health. That's normally the way people would experience it. The second one is a parallel model, which is the one I worked in for a long time. So 2 separate services provide care and support concurrently, liaising to provide the 2 elements of treatment. What I found was that there was a parallel model that existed when I was working in North Mayo, where I was doing my work with the client around their substance misuse, and they were also linking in with a mental health service, but there was very little contact. I would try and make contact, but I wouldn't have any meaningful contact with the mental health service. The third one is the integrated model, which is kind of like unicorn territory, really, that we're kind of going into. And the HSE will tell you that they do have an integrated model, and on the face of it, they kind of do. So they do have a full multidisciplinary team. They have a lot of people coming in and coming out. If you get into that service, you have access to a multidisciplinary team, which is great. What I'm saying is that an awful lot of clients are not in that service. They just don't get through the door. They just don't get in. So even though I think the HSE will be quite robust and say, look, we do have an integrated model, just think about the number of voluntary agencies that your local multidisciplinary team has meaningful relationships with. So again, just to kind of think about that. Just the next slide there, Megs, thanks.
Okay. Sean, I don't think people can actually see you actually, so that's just, I'm trying to fix it, but I can't.
Oh, don't worry.
Can they actually see Sean?
You're missing nothing. You're missing nothing.
Okay, go for it.
So hopefully what's up in front of you there is, so what's it like for someone who has a dual diagnosis? So, okay, so there's a couple of things to think about, right? One of the things that I found quite interesting is somebody has an addiction and they've got a mental health issue, right? And so the crack is they're trying to get a service for themselves. They realize they need a bit of a service. And you could be talking about somebody who has been traumatized, somebody who has maybe a long history of rejection. I don't know. I'm not saying this is the case in all cases, but just as an example, I just think it's quite interesting what we do. And essentially what we say to people is, look, you're actually not good enough, in inverted commas. We're not actually saying that, but we kind of are. So you're not good enough yet to come into services until you sort out your addiction or until whatever. And sometimes the idea is that there isn't necessarily a role for harm reduction within, say, a medical model. So you can understand how confusing it can be for a client. Somebody with a dual diagnosis might be coming into a mental health team if they're lucky enough to get access to the multidisciplinary team. And it may be a medical view of addiction, which may possibly be abstinence-based, okay? And there may not necessarily be the expertise around illicit drug use within that MDT. There may not be. And that same person then comes into a community-based drug service where people are talking about harm reduction. They're talking about trying to minimize the harm. They're just trying to work with somebody where they're at. You can see how confusing that is for somebody if they access 2 services. One is maybe saying one thing and another one is saying another. And it's just basically 2 models. We've got a medical model and we've got a social care model. And really the ideal thing is that we all work together. But you can see that sometimes for people trying to access services, being told that you need to sort out your addiction first of all and then come into treatment is just a step too far. They just may not be able to do that. Maybe the thing that holds them together is their drug use. Yeah, essentially the people with the most complex needs may not receive an appropriate service. And clients often say to me, it's like ping pong. Do you know what I mean? Like, you need to go over there, no, you need to go over there, But just before we move on to the next slide, is just imagine the emotional strength that you would need to navigate your life with the dual diagnosis. Just imagine that. These are not straightforward things. Okay, and so I suppose just to the next slide, please, Mags. But what I would say is that from my own perspective, I just think anybody that successfully navigates a dual diagnosis for any length of time has unbelievable strength and resources. Like, just really like hats off, especially trying to access a service that is very unforgiving. So hopefully the dual diagnosis clinical program is up there in front of you. Is that right, Mags?
Yep.
Yeah, good. So just very quick one. It's just, where is it? So we have a clinical program on dual diagnosis. I'm not really sure where it's at the moment. It met for a while. It doesn't seem to be kind of going forward now, but there was a dual diagnosis clinical program in place. Maybe we can talk about that as a group afterwards. Just the next slide, Max, thanks.
Yep. Oh.
Just very quickly, so because I'm just kind of conscious of time, but just some things for you to think about is, if you get a chance, try and read John Reed, R-E-A-D, John Reed. Got a very good book called Models of Madness. The Hearing Voice Network is a great support for a lot of people that may experience voice hearing. Peer support is very, very important. The Norwegian model, just put it in there very quickly, is they've made it, I believe, they've made it part of their constitution that when you go on to a ward, you can choose not to be medicated, so you can live without having medication, which I think is the way that we should be going here, but I think we're a long way off that. So if you go in and you're hospitalized, you can say, look, I don't want to take any medication, and that's respected. Open dialogue, popular in Cork. Again, Cork is just great, doing a whole bunch of stuff. If you just Google it, because I'm just conscious of time, it's very good though. It's very, very good. And adverse childhood experiences, obviously, Sharon has spoken about that. So what I might do, if it's okay, because I'm conscious of time, Mags, sorry for the delays, if you just move forward 3 slides and you'll see a thing called Chime. If we can just kind of go to that, that would be great.
Yeah, that's up now.
So this is recovery in mental health. It's a thing called Chime. So it's Mary Leamy and Mike Slade and a couple of other authors. It's fantastic, really. And what they do is they did a review of kind of what works in recovery in relation to mental illness, and they came up with the Chime. So it stands for connectedness, hope and opportunity, identity, meaning and purpose, and empowerment. So if you just think about those 5 pieces kind of put together, and you think about ourselves in relation to any kind of recovery, including addiction, I just think it's a nice fit. So I think we have an awful lot more in common with recovery from addiction and recovery in mental health than we have that's different. Thanks very much, Megs. So might just go to the next slide.
Yeah.
So barriers to mental health recovery, interestingly, for the Mental Health Commission in 2007 is a dominance of the medical model, which oftentimes can be risk averse. So they won't necessarily take positive risks with people. Public opinion and stigma, resistance from service providers. And again, this is the cultural piece that I would kind of highlight that I think we probably need to, well, not probably, we need to change. Lack of multidisciplinary teams and lack of understanding of the recovery model. If you take out recovery model and you put in dual diagnosis in there, I think that kind of sums it up. And a lack of evidence-based research for the recovery model. So if you just go to the next slide, Megs. So we just got three slides left and then we'll be done.
Yeah, barriers.
Okay, so these are barriers to treatment in relation to dual diagnosis. Difficulties in conceptualizing and defining dual diagnosis. Difficulties in recognizing and assessing dual diagnosis. And again, it's not as straightforward as you'd imagine. Actually assessing your own dual diagnosis is quite difficult. But again, that's absolutely no reason to say that you can't do it. I mean, open heart surgery is difficult too, but we do it, don't we? We just do it. Service are not client-centered. We got the stigma that Carol referenced kind of earlier on. Inaccessibility of services. No, you need to come back. Lack of communication, lack of structure and protocols in and between services, that's definitely the case. I often worked with clients when I worked with the drug service, and I didn't really have any contact with the mental health service, even though the client was seeing both. And it wasn't from a lack of training from my end. Fragmented care, professional ethos, and perceptual culture. So this is the way that I work. I've always worked this way. I'm not going to change it. We just go to the next slide. Thanks.
Yeah, recommendations.
Yeah, so these are just some recommendations, and okay, stick with me, and thanks for sticking with this, because it's not very often I talk to a blank screen. I hear people in my ear. There's thanks for this. I'm very sorry that this has happened, but nonetheless, dual diagnosis needs to be recognised and addressed in national policy, particularly in relation to mental health, drugs and alcohol. Grant. It potentially represents a significant number of people accessing primary care, so addiction and mental health services. And services must provide for dual diagnosis at a local and a national level. And I think what we have in relation to dual diagnosis is fairly patchy kind of response. I think some areas are very good, maybe, and that a lot of that is down to possibly the psychiatrist that's working in the area who may have an interest. Cultural difference, treatment ideologies, and the lack of education and understanding in relation to dual diagnosis needs to be addressed. But there's two things I'd say to you. You can train people until the cows come home, but the bottom line is you need to implement it. So you can get trained up in being trauma informed, you can get trained up in dual diagnosis, but what we actually need to do is to monitor what we're doing. We need to implement, monitor, and review. So I think there's an awful lot of people who would say, you need training in this, you need training in that. That's sound. But actually what we need to do is try and work out, is this actually working on the ground? And if it is, how do we measure it? We need to do that. My fear is that everybody gets trained, but nobody does it, that kind of thing. And just the last slide there, Mags.
Yep, last recommendations.
So just clinically effective service models and treatment approaches that need to be developed that fit within the context of the Irish healthcare system. It's a big ask in some ways, and in other ways it's not. It's not. We just need to do our work. The bottom line is everybody pays taxes in this country, more or less. And the bottom line is we all need to get a service. And if we have a holistic response to an identified need, in this case dual diagnosis, then we're going to get somewhere. But if we keep doing what we're doing, we're going to get what we're getting. So we need to change in some way. Increased research is needed. Just looking at things like prevalence, needs assessment, service user experience, and management of dual diagnosis, and develop national guidelines for dealing with the complexities of those with dual diagnosis, which the dual diagnosis program was, I think, working on, but I don't know where that's at right now. So that's me. Listen, I'm really sorry, guys. I went over by a few minutes. I'm very sorry about that. And I can't actually see my screen. So if you have any questions for me, I'm very happy to answer them or do whatever I can. Thanks very much, Max.
Thanks so much, Sean. I think you got really shy there near the end, Sean, and you hit on us down. Thanks so much for that. Once again, really, really important information and lots of recommendations there, I think, that need to be really looked at, and they need to go forward. Like, it needs to be from the tops down. We're talking here about the bottom stuff, but it needs to come from tops down as well. Yeah. Thanks so much to the three presenters. Just conscious of time, I'm going to invite Tracy now just to give us a brief intro. We will also send this information out by email to people of the services available.
Okay, hi everyone, and thanks so much. That was so brilliant. I'm just going to talk through some of the resources available in the local area. Because it can be a very isolating experience for the person with addiction or the family members of those with addiction or friends. So it's good to know that there are some really good support services in the West. So I'll just start by mentioning the Western Region Drug and Alcohol Task Force. And this presentation today was organised by them, so Mags is part of that. They provide training, education and support for people affected by addiction. They also, at the top there, you can see Planet Youth. The Western Region Drug and Alcohol Task Force developed this, and it's running out in Galway, Mayo and Roscommon. And they work with the community to improve the lifestyle and health of young people in the area to prevent them turning to drug and alcohol abuse. Then there's the recovery colleges. I don't know where that is down the bottom there. They provide educational courses and training on mental health recovery, and that's in Galway, Mayo and Roscommon as well. And those courses are facilitated by people who have lived experience of mental health challenges, so that's very important. A good first place to turn to are the family resource centres, and there's over 120 in Ireland, so there's probably one in your town. If you go there, you can get a range of support services, and they offer low cost counselling subsidised by the resource centres. So it's a great place. If you don't know where to turn, or you don't know what help you need, they'll point you in the right direction. There's also on that list there are the rehabilitation clinics, AA, Al-Anon. Al-Anon is for family members and friends of addicts. So that's a peer support group. And myself, I'm from Grow Mental Health, and we provide peer support groups to people with lived experience of mental health challenges. And we are currently running online because of COVID, but we have groups in Mayo, Galway, Roscommon. So we'll be coming back into the community again once the restrictions lift a bit more. So if you go on our website, grow.ie, you'll find more information on that. And I think that's about it. We'll be sending this out after this presentation to everyone, so you'll have the full list. So thank you.
Lovely. Thank you so much for that, Tracy. I know we were going to look at having a small opportunity for questions and answers. I know some of it has been going on in the chat as well, some answering of it. I might give the opportunity for 1 minute to each speaker. If there was any particular question there that you found that was relevant for you, if you want to give just 1 minute maybe answering that, and then we will jump to the raffle and close. So thank you. If I jump to Sharon first, Sarah, if anything stood out to you, please, Sharon.
God, there was loads of questions and they were all so different. So I think actually to kind of just the thing I'd like to finish on is that it's really important that we challenge the stigma in relation to mental health and addiction. So we've done a lot in the last few years in relation to mental health. Now we need to challenge the stigma in relation to addiction. And if you are concerned about yourself or other people that you should reach out for help, you should always go to people who come highly recommended. And if you go to see somebody and you don't click with them, give it 2 or 3 sessions, and then you need to find somebody else. I might go to a restaurant. Well, I wouldn't be going to a restaurant now, but in the past, I used to go to restaurants before COVID. And if I went to a restaurant and they served me a meal and there was absolutely nothing wrong with that meal, it just wasn't my cup of tea, I wouldn't keep going back and spending money on that food in that restaurant. I'm somebody who has no problem going to see a psychologist if I'm concerned about my mental health. And in fact, the person I'm with now, touch wood, I don't have to see him very often, but anytime I'm worried, I do go pop along to see him. I've been going to the same person for the last 10 years, but I would have gone through 5 or 6 people before I found the right person for me. That doesn't mean that there was anything wrong with me or anything wrong with them. It's just that this is a professional therapeutic relationship, and you have to have a connection with that person for the best work to be done. So always reach out. If you're not happy with what you've got, value yourself just like you would if you went out for a meal, to move on to the next person.
Brilliant. Thanks so much, Sharon. And I think that's a really good way to make us think differently about that. So that's a really good analogy. Carol, up next, if you just want to summarize anything, or if there was any questions that stood out for you there today.
Yeah, just agreeing with what Sharon said, it's really important to find somebody that you can actually work with. And in the A to Z, we cover a range of questions you can ask to see, is this counsellor actually working for you? And the thing to remember is counsellors in Ireland aren't actually ready. The psychologists are, but psychotherapists aren't. That's only being set up now. So somebody can do a weekend course and call themselves a psychotherapist as it stands at the moment. Now that is changing, but just, to be aware of that. The other thing to be aware of is, when you're dealing with somebody in addiction, it can be incredibly challenging. And so if somebody is saying, and I've had this experience where I was, so well, in that place, I have to sleep on a mattress. And I'm kind of going, no, that couldn't be true. And then when I actually checked it out, it was true. The person was sleeping on a mattress. So it can be very difficult to distinguish between, somebody trying to avoid accepting help and somebody who actually has a genuine reason for not accepting help. So that's where, again, asking the right questions and helping the person ask the right question can be useful. The other thing is as well, psychotherapy isn't for everybody, that particularly when there's trauma involved and the brain isn't engaged, body work can be very useful to help the person start feeling safe. And maybe it's about doing body work, which is, can be yoga, tai chi, meditation can be very useful. And they have to do that before they can actually calm down enough to get benefit out of the therapy. But a good service should actually talk you through that and go through all the different options with you. And yeah, I've encountered services when you say, well, what body work do you do? And they don't do any body work. So that's another important issue to look at.
Thank you, Carol. Yeah, really important point. I'm so interested in that aspect myself of the body. And if you even look at some of the books that we have in the raffle here today, in relation to when the body says no and the body keeps the score, they really advocate for those techniques where you actually use yoga to relieve the stress and breath work. So really good point there to finish up with. And finally, Sean, I think we can see you this time if you want to just finish with anything.
Yeah, so I suppose just to echo really what Carol and Sharon are saying, just thanks very much for inviting me. I'm really sorry I had this technical difficulty, but it just goes to show if you keep plowing on, you just get there in the end, man. You just get there in the end. So yeah, so I often say to people that if you're trying to get a therapist, and this includes when people get in contact with me for private work, I say that like kind of getting a therapist is a bit like changing your car. You might have to test drive a few before you get one you like. And that's okay, like it's absolutely okay. And what I would say is, I suppose both somebody who's really benefited from therapy myself, and then obviously as a clinical psychologist providing therapy to people, I think therapy can be wonderful. It's just about the fit. If you can get the right person, it's okay, and not to give up on it. And I suppose the last thing then is just that ideally what you're looking for is that somebody has compassion and understanding. And that I think that we need to have compassion and understanding ourselves. And so from my own personal point of view, I was seeing a therapist for about, I still do see a therapist occasionally, but I was seeing a woman fairly regularly for about 7 years. And she was the least qualified and the absolute best. and she had the absolute bare minimum of qualifications. But the thing that made her stand out was she cared within a boundaried therapeutic space. And she was compassionate. So I ended up doing some really lovely work with her just on a personal level. And it really helped me an awful lot. So my fear is that you might try and go, and a bit like you're saying, Carol, you might go to see somebody who's done a weekend course and, she would do a bit of breathing techniques there, which you'd be sound. and then you might get put off. And I think the key is look for somebody who is qualified and compassionate. That's what you're looking for. That's it. And thanks for inviting me, man. It's been great, Max. Thanks.
Thanks for joining us, Sean, as always. I think that's a really important final point as well, is in that compassion, having compassion for what's going on, because we never really know what it's like to stand in someone's shoes, and just having compassion, accepting them where they're at, and they'll be able to accept themselves and too. So thank you, Sean, for that final nugget of information there. Just finally then, I will go to Becky. Just before I do, big thank you to all the speakers here, for the two ladies that came on board as panelists as well to help out, to the development group and everyone that's helped out today. I can see some really positive comments coming in here that has been really useful talk, really useful information. We hope to follow up on this topic throughout the year with different pieces, so you can keep an eye on that through the task force or through our Facebook page, Mayo Drug and Alcohol Family Support. So over to you, Becky, and thank you, everyone.
Thanks a million, Max. Thank you to Sharon, Carol and Sean. Very informative, thoroughly enjoyed this, and I was so glad to be part of the development group for this webinar. I'm going to do the hamper now. I have the names all here in the bowl. Okay, so I'm going to just randomly call them out there. I don't know if Max has the books with her, but I'm going to go with this one first. So this prize is for a book called Beyond Addiction, How Science and Kindness Can Help People Change. It's Guide for Families by Jeffrey Foote et al. I hope I'm saying these right. And then there's another book with that prize, When the Body Says No to the Cost of Hidden Stress by Gabor Mate. I hope I'm saying that right too. So the winner of that prize is Jane Murphy. I'll make note of these, Max.
Oh, good woman, brilliant.
Okay, and then the next prize for 2 books is How to Do the Work by Dr. Nicole Lepera and The Body Keeps the Score by Bessel van Kolk. And the winner of that prize is, and then we have a hamper sponsored by myself. It's a hamper full of self-care goodies, and I have 2 books in that hamper, courtesy of my page Minding Me on Facebook. And the books in it are What Happened to You? Conversations on Trauma and Resilience and Healing by Bruce D. Perry and Oprah Winfrey. And there's also a book in there from Russell Brand called Recovery from Our Addictions. And the winner of that hamper, which I will be posting out myself, is Jerry Diamond. So that's that, Mags. Those are the 3 winners. So I'm going to make note of that.
Lovely, lovely. Thank you so much, Becky. Everyone, enjoy your day, and thank you so much. Okay, take care, everyone. Well done, Jerry. I can see the excitement coming in there.
Congratulations.
Take care.